Welcome to the Cardinal Minute with your host and chair of the University of Louisville Department of Medicine, Dr. Kim Williams.
Well, good morning and welcome to a Cardinal Minute. I'm Dr. Kim Allen Williams, chair of medicine here at University of Louisville, and I'm joined by Dr. Mohammed Saad, our chief of the Pulmonary Division. And we were thrilled this morning to have a wonderful Grand Rounds presentation from Dr. Rachel Foote, who's an assistant professor of medicine and co-director of the post-COVID clinic at the University of Cincinnati College of Medicine. She presented a talk entitled COVID and Beyond, Pulmonary Manifestations of Post-COVID Syndrome. Dr. Foote, can you summarize in 1 minute your talk?
Yeah, thank you for having me again, Dr. Williams. And in 1 minute, I wanted to illustrate that we saw a lot of very severe acute COVID pneumonia through the pandemic, which luckily is becoming less and less prevalent. But following those severe acute illnesses, a lot of patients have been left with persistent pulmonary deficits in the manifested by pulmonary fibrosis and other types of interstitial lung diseases with secondary to COVID. And these patients have some pretty significant dyspnea. Additionally, with patients with long COVID, there are a lot of patients who had very mild initial disease, including patients that did not require initial hospitalization, and even some patients who didn't have much in terms of initial symptoms, who have been plagued with persistent dyspnea, brain fog, cough, chest pain, being some of the most common symptoms that can wax and wane, but after COVID infection that lasts, at least 3 months generally. There's a lot of theories as to the potential pathophysiologic mechanisms to this process of long COVID or post-COVID syndrome, still being hashed out, and probably not all patients fit in the same bucket of why they have persistent symptoms after COVID infection. A lot of patients have probably some neuroinflammation going on, and some patients potentially have some dysautonomia or postural orthopedic tachycardia syndrome. And other potential mechanisms include diaphragmatic dysfunction or deconditioning, not necessarily related to a severity of acute infection. It's important that we listen to these patients and hear them out and come up with, an initial workup for them, and make sure that we don't see, life-ending events, significant abnormalities on objective testing that would be potentially life-ending for them. But it's also important that we try to treat their symptoms as much as we can, which sometimes just includes breathing techniques and yoga breathing and pulmonary rehabilitation.
Well, thank you very much for that wonderful summary. We really appreciate all of your insights, and look forward to working with you further on this topic. And thank you very much. This has been a Cardinal Minute.